Okay, let's get started. And good morning, actually, good afternoon, or good evening. I know that we are all from different time zones, different countries, and welcome to joining SBRT, SRS remote training. Today is the third training session. And in the past 2 or 3 weeks, we discussed about the brain, radiosurgery, SBRT, and actually early this week on Tuesday, we talk about the prostate. And if you missed the first 2 sessions, you should have received the link about recorded videos. You can watch over there to learn more about SBRT and SRS. Yeah, please mute your microphone, and you can change your name so we can recognize where are you from. I see people from Argentina, from Mongolia, from Chile. So if you have questions, please raise your hand or type in the chat. And also, I will keep copying the registration sheet so you can put your name over there. As I said, if you join 5 of 6 training sessions, you will receive a certificate from us. And also, Geneva sent out you surveys, not only about the pre-training survey, so we understand the baseline knowledge, baseline knowledge about SBRT and the SRS, and also please provide your feedback and about this training session. So in this way, we can always continue to improve, understand your needs. Before I introduce our speakers today, I want to actually answer a common question because in last 2 sessions, people ask about what's the margin should I use for SBRT or SRS. This question is really depends on your institution, and the idea is, of course, you want to reduce the margin because this is a high dose. It's kind of a radiosurgery, right? But it really depends on your confidence level, your experience, your equipment. For example, I have for brain mass, the margin. I've seen people using 0 millimeter margin from GTV to PTV. And because they have a lot of experience, they are very confident in their imaging equipment. And I've seen a 1 millimeter, 2 millimeter, 3 millimeter margin for brain mass. And it really depends on your immobilization device, your imaging, and how good is the quality of your imaging. Then last week, same question for prostate. What's the margin should be used for prostate SBRT? And I know some institutions using 5 millimeter, some places using 3 millimeter. It really depends on, do you have a 6 degree of couch? Something, how good is your immobilization? And do you have like fiducials, for example? Yeah, and how good is your imaging quality? So this question can be varied, but I mean, for many known middle-income countries, I highly recommend, in the beginning, probably give a little bit more margin. Once you gain more confidence, you can reduce the margin. That's basically general comments about the question. Again, also you can request the scripts. Ideally, I wish I could find a translator. I know many of you come from Central or South America, and probably Spanish is your native language, but I think you can see the script, hopefully. Okay, today, this is the training schedule. Today, we are going to talk about SBRT for lung and spine. So every session, we have different focus. You can see that the last session will give a planning demo. If your institution have interesting examples, you can send me, your CT images and your structures, and we can test our system first, then we can actually give a demo for institution. Today's speaker is Dr. Desai, and he's radiation oncologist at the Baylor College of Medicine, and he's the medical director at Baylor St. Luke's Hospital, one of our center here. And he has many years experience for lung and spine and breast hyperfractionation. So He's going to talk about this topic. We also have every session we have a physics talk except session number 5. So Dr. Xu received his PhD from Louisiana State University, and later on, she was trained in medical physics residency from University of Maryland. He recently joined us as a faculty and a medical physicist at the Baylor College of Medicine. So Dr. Tsai, all yours.
Sure.
I'll stop sharing.
Sure. Good morning or good evening, depending on where you are in the world. Let me share my screen, make sure everyone can see it. Can everyone see the presentation, Dr. Sun?
Yes.
Okay. So like Dr. Sun mentioned, Snehal Desai, I'm a radiation oncologist. I've been practicing here in the Houston area in my residency and training at Baylor College of Medicine as well. And today I'll be talking about some cases where we can look at SBRT lung and spine plans and looking and reviewing some data as well. So there's a 60-year-old gentleman with a 30-pack year smoking history who presented with a cough. He was COVID negative, no shortness of breath, no weight loss, no chest pain. He went to his primary care physician who did a chest x-ray, which showed this right upper lobe nodule, which you can see in the arrow pointed with the orange arrow. He underwent a diagnostic CT scan, which showed that right upper lobe nodule. There was no other mediastinal lymph nodes or no other disease. He had a PET scan done, which also showed a uptake in that right upper lobe nodule, SUV of 7.2, and no other metastatic disease throughout the body. This lesion was biopsied, positive for adenocarcinoma, lung primary. He was staged with EBUS, and lymph nodes were negative. So the management of early stage lung cancer, if we look at the NCCN guidelines, if they're operable patients, surgical resection is an option. And if they're medically inoperable for no negative patients, definitive radiation. And radiation is typically what we call stereotactic body radiation therapy, or SABR, stereotactic ablative radiotherapy. And this is for stage 1 as well as stage 2 tumors, which are lymph node negative. If you look at the recent data, if you look at patients with metastatic disease, say for colorectal cancer, and they have oligometastatic disease to the lung, SBRT is also in the NCCN guidelines for these patients as well. So if we look at early stage lung cancer, if they're medically operable, as we saw on the previous slide, surgical resection, which is a lobectomy and mediastinal lymph node dissection, is the standard of care. And the 5-year overall survival for these patients is about 80% for T1 tumors and around 70% for T2 tumors. However, if they're inoperable, these patients are not good surgical candidates, either due to their history of smoking or COPD or other risk factors, which make them a not good surgical candidate. So these patients can be treated definitively or with curative intent with stereotactic body radiation therapy. And when we do this, we know that from previous trials that we don't need to treat lymph nodes that are not involved. However, these patients, since they aren't surgically, since the lymph nodes are not removed, they can fail in the lymph nodes. However, in this patient, we did do sampling of the lymph nodes. If you do a PET scan only, 10 to 15% of patients may have disease in their lymph nodes, which we cannot see. So for our medically operable patients, lobectomy is the standard for, however, we'll also talk about SBRT for medically operable in a few slides. For inoperable, we really want to focus on radiation. So there was for patients that are operable, lobectomy is a standard. However, if they do a smaller surgery, like a wedge resection, there was this trial from the lung cancer study group that showed a 75% increased rate of recurrence, so 18% versus 6% recurrence by doing a smaller surgery. So this is very important when you're having a multidisciplinary approach and talking about treatment options for patients. Sometimes if they're doing a smaller surgery, then maybe SBRT has better local local recurrence rates than a wedge resection. So something to discuss with your thoracic surgeons and other colleagues which you collaborate with. So looking at radiation for medically inoperable. So there are many different definitions of stereotactic body radiation therapy, and my take on it, it's high dose per fraction. Here in the United States, we want that to be 5 fractions or less. In other countries, they can have more fractions in their definition of SBRT, but from an insurance standpoint, they consider that 5 fractions or less. There's more potential damage or cell kill for tumor, but also potential damage for healthy tissues. And so the importance is to have small treatment volumes and basically exploit the advantage of a rapid fall off. When we look at fractionated radiation, which we're all familiar with, this is low dose per fraction, right? 1.8 to 2 gray per day, maybe a hypofractionated approach now, up to 3 to 5 gray per day. Many fractions we're looking at, 2 to 3 to 4 weeks of radiation. However, this is less ablative, but also safer for normal healthy tissues. And a lot of times you may have a little bit more margin on these tumors. So when we look at radiation therapy, if we did just standard fractionation, just 2 gray or 1.8 per fraction, looking at retrospective studies, and they used to call this a postage stamp field, which is, if you look at a stamp that you put on a letter, it's a small field which just treats the tumor. And they showed that even with very high doses of radiation, the local control was very low. And so we know that standard or conventional radiation therapy, regardless of the technique, is not an ablative or curative treatment for these patients. And so for medically inoperable, there was a study, RTOG 0236, which looked at stereotactic body radiation therapy, where they give 54 gray in 3 fractions compared to the standard fractionation of 60 gray in 33 fractions. And we previously saw only had a 50% control rate. But with giving very high ablative doses of radiation, you can see the local control rate in the lesion was 98% and 91% in the lobe, despite not treating, by just treating the lesion itself. And so there's also experience from Beaumont, which shows similar control rates, very high control rates with stereotactic body radiation therapy versus standard fractionation. And looking at the outcomes, like we saw, 98% tumor control, there was only 1 primary tumor failure. The 3-year local control was 91%, and the median overall survival was 48 months. So very good and very effective treatment in these patients. And if we look at the patterns of failure, one of the criticisms with SBRT is that, we're only treating the lesion and not removing the lobe compared to a lobectomy. But the failure rate in the tumor was very low. In the involved lobe was very low. Hilar recurrence or lymph node recurrence, like we talked about, they could have a false PET negative if they're not surgically staged or staged by endobronchial ultrasound. However, a majority of the failures were outside of the lobe or outside of the lung. And so I think stereotactic body, based on this trial, is a very good option for these patients. And if we look at the data, how do we come up with these doses? If we think about 54 gray versus the 60 gray in standard fraction we talked about, we think that 54 gray is a lower dose. However, when we calculate the biological equivalent dose, and that's basically the effectiveness of the dose, we can see that the 54 gray is better than the 60 gray, as the data showed. And this trial from Onishi basically showed us that if we can calculate a BED greater than 100, then our local control rates are 80+%. However, if the BED is less than 100, then it's only 37%. And so same thing with overall survival, 70% versus 50%. So in a patient that we treat 54 gray in 3 fractions, the BED is approximately 110. And so we know that that's a very good ablative and curative dose. So the nice thing is about SBRT, it's convenient. for the patients, less time off from work, and actually has a better control rate, and experience from WashU that, very few treatment-related deaths, very low pneumonitis, as well as chest wall toxicity, which we'll talk about. Now, patients which are medically operable, these are patients who can go to surgery. However, in our institution, we do a multidisciplinary approach where they meet with the radiation oncologist and they meet with the thoracic surgeon and look at different treatment options. And sometimes patients may say, hey, I don't want to have a surgery, and go through the recovery. And those patients treated with stereotactic body still show an excellent local control and actually a wonderful overall survival as well. So this patient was discussed in multidisciplinary tumor board. His staging scans were negative, and the patient was a surgical candidate. However, he decided not to have surgery. So the way we simulate these patients is in a vacuolock bag. As you can see here, it's a bag which is molded around his body. His arms are up above his head, so that way we can treat the lung without treating through the arm. And we use a very long body bag, so that way the patient is basically completely encompassed in this bag. And when we do this, there's very little motion or change in position from simulation between each treatment. The CT scan is performed without contrast since we're only treating the lesion and not treating lymph nodes. Thin slices, and then we also do a 4D CT to evaluate the motion. And so we know that these tumors in the lung move with breathing, and lesions that are higher in the lung typically have less motion. However, lesions in the lower lung can have more motion. And so we can decide the best treatment strategy, whether we treat an ITV or do a gated approach, which we'll talk about shortly. So the most important thing is that patients are comfortable so we can reproduce this position, and then we fuse this with a PET scan. So if we look at this case, the lesion here, we contoured it in lung window, we contoured it, in this case, we contoured the entire ITV here in red, had very little motion. So we looked at it in all the phases and contoured it. We also contoured it in the MIP as well as the average to create this ITV, which is here in red. And in this case, we did a 5mm PTV in this patient. Typically, lesions that are lower, that may have more motion. If you're not doing respiratory gating, you may want to do a 7mm superior inferior margin, and then a 5mm radial margin. But like Dr. Sun says, based on your institutional experience and technology and imaging, that PTV margin we'd recommend based on your center. And so when we're doing this case, it's 54 gray in 3 fractions. So looking at different organs at risk constraints, these are based on different protocols. So looking at the 3 fraction dose, we'd limit the different areas of the body. This is a very straightforward plan because it's in the lung. So the biggest risk factor is the lung adjacent to the tumor. And so we really want this to be a very conformal plan and have a very good conformality index, which we'll talk about shortly. For lesions that are near the chest wall, there's data showing that if you can limit the cc's of chest wall, 30 cc's less than 30 gray, or at 30 cc's at 30 gray, this decreases the risk of chest wall injury or pain. However, in some cases, you may need to increase that cc based on the lesion or size of the lesion that's against the rib. And in those patients, you may need to counsel your patient about rib pain or fracture. And so if you look at this patient's plan, he was delivered 54 gray in 3 fractions. The max hotspot was less than 130%. If 125% hotspot. If we look at the conformality index, which is the volume of the prescription line divided by the volume of the PTV, it's very close to 1, and that's very good. We typically want that to be less than 2. And if we look at all the critical structures, they're very low, which we'd expect in this plan because the lesion was only in the lung. In patients where the lesion is close to another critical structure, your conformality may not be as good because you want to avoid that risk, organ at risks. For example, if it's a paraspinal lesion near this cord or the esophagus, or the bronchial tree, which we'll see shortly, those are patients that we may want to adjust the focus on the organ at risk versus tumor coverage. And so we look at clinical goals, which tells us that it meets all of our constraints based on the previous criteria. So this is a very good plan. And so after the physician has approved the plan, you'll go to QA and then treatment delivery. When we treat the patient's treated in the same immobilization system. Once the patient's set up, we do a cone beam CT with the physician and physicist present, make the shifts, and then the patient radiation is delivered. This was delivered in 2 arcs, so the treatment's approximately less than 5 minutes. We also use surface-guided radiation therapy to make sure the patient isn't moving during the treatment, which also helps build confidence in our treatment delivery. And so when we look at local control with radiosurgery, this is another patient, but if we look at that lesion over time, you can see that the lesion can shrink or disappear. However, in some cases, you can have a lot of changes. So if this is the initial tumor, you may have a lot of scar tissue or what we would call radiation pneumonitis. And these patients can present, within months, typically around 3 months, with shortness of breath, cough, similar symptoms to having pneumonia. And these patients are managed with antibiotics and a very slow steroid taper, typically prednisone, over multiple weeks to months to help minimize long-term fibrosis and scarring of this lung. There are studies that say, in these patients would have poor lung function to begin with, do we worry about their lung function afterwards if they have this fibrosis-like effect on imaging? And they actually show that the diffusion is actually improved post SBRT in these patients. So their oxygenation of the lung is improved for that area that was occupied by that lesion. In a second case, this is a patient with a lower lung tumor, and you can see that the interior red line is the GTV, and so that was drawn on the average scan, and all of our patients are planned on the average scan. And this blue is the ITV. So you can see that the tumor does not just have superior inferior motion, but also has a diagonal motion. And we see this a lot in patients, depending on how where the tumor location is and their breathing cycle. So we created this ITV, and then around the ITV, we did a 5mm margin because we felt like that ITV and the 4D CT was very reproducible. You can see it on all 3 planes. This lesion is also a little bit closer to the heart, however, able to meet the heart constraint because we have plenty of margin or plenty of distance between the heart. And so this patient, typically in patients that are more central, I like to use a dose of 50 gray in 5 fractions. By using a few more fractions, that gives our critical structures a little bit more dose or tolerance. The maximum hotspot in this plan was also about 134%, and then in our stereotactic plans, compared to our IMRT plans that we typically limit to 110, we want these patients to have very hot plans because that's how we get that ablative dose, right? So the center part of the tumor or the ITV or PTV are getting very high dose, and the goal is to have an ablative dose, but really have the conformality very good. And in this case, you can see that the conformality is also 1.06. All the critical structures also meet tolerance to making sure that we are treating this patient safely. We contour all the organs. For example, this patient even had the ribs contoured, even though it's so far away. So that way, we're evaluating all of our critical structures regardless of the location of the tumor. Now, when we look at central tumors, the previous case was a little bit more central than the initial peripheral case. But when we're looking at central tumors, we really worry about our airway, mainly our proximal bronchial tree, our trachea, as well as the esophagus. Those are probably the three most critical structures that we worry about when we do central radiation. And this was published in the New England Journal that this patient had basically necrosis of the airway. And a very interesting finding that we know that these structures are very sensitive to radiation. And so, we consider patients with central tumors greater than within 2 centimeters of the bronchial tree. However, ultracentral tumors, which are within 1 centimeter of the bronchial tree, have a higher incidence of grade 3 and grade 3 to 5 toxicity. And so outcomes and side effect profile of SBRT are dependent on the tumor location and the dose and fractionation we give them. And so patients with central tumors 2 centimeters from the bronchial tree, and then ultracentral or within 1 centimeter or touching the proximal bronchial tree. This is a paper showing that higher incidence of when they're treated within 5 fractions of tracheal stenosis, hemorrhage, fistula, as well as risk of bleeding if they're on anticoagulation, or increased toxicity if they're on systemic therapy as well. And so if we look at the International Stereotactic Radiosurgery Guidelines for ultracentral and central tumors, they recommend maybe a more hypofractionated approach. They're considering this SBRT, but in the United States, it's 5 fractions or less. So giving 60 gray in 8 fractions or 60 gray in 15 fractions may be appropriate. You want to avoid hotspots within the proximal bronchial tree and esophagus, limit the global Dmax to less than 150%, making sure that you're sparing your critical organs so your PTV coverage may be lower and may not have as conformal of a plan. And then making sure you discontinue antiplatelet or anticoagulation therapy if it's safe for the patient. And then concomitant SBRT with targeted or immunotherapy could be avoided in certain cases if they're having certain inhibitors. Let me see if there's any questions before we move on to SBRT spine.
Yes, let's question in the chat. What considerations do you have in dose and the planning when there is a patient with COPD in the lungs?
Sure. So let me see. I don't know. Yeah. So the most important thing is, seeing what their risk is. We get pulmonary function tests on all of our patients. We want to make sure that their pulmonary function tests are lower than being a surgical candidate. So many of these patients can have decreased lung function. However, it's a balance between treating COPD patients versus their tumor control. So a lot of times we'll counsel them on having this fibrosis, or talking to them that they may need oxygen use, depending on if they're on the fence of needing oxygen already. We've safely treated patients with COPD and on oxygen. And if you look at that previous slide where we were talking about the fibrosis, their DLCO, which is the oxygenation, actually improves after SBRT. And so that area of the lung, which is occupied by the lesion, that area is not perfusing. So hopefully after doing stereotactic body, that area becomes perfusional. I think the goal is to limit the volume and try to have maybe in physics they'll talk about it, the D2 cm dose, which is the 2 centimeter dose, to have that very tight and conformal. We typically want that to be at 50%. So the less lung volume, or depending on the beam configuration or arcs, to minimize dose to other parts of the lung. So doing a partial arc rather than a full arc can also spare dose to the contralateral lung.
Thanks. I have a question, actually, probably on behalf of many people from low and middle income countries. And many institutions, they do not have PET-CT. Can they still treat?
Yeah, I think PET-CT is helpful to do a full body staging. In our experience, majority of these patients with early lung cancer are patients that go under lung screening programs. Those are patients who have a higher smoking history or current smokers, and the goal is to find these tumors earlier. And so if we can't get a PET scan, the importance is to do a full body CT, chest, abdomen, pelvis CT, make sure that's negative. Look at the lymph nodes, sample the lymph nodes if that's possible, because we don't want to do a localized treatment if they have regional disease or metastatic disease. But depending on what technology or imaging you have in your country, we may have increased failures in those patients if there's something that we can't see. But remember, PET also has a resolution of 1 centimeter or greater. So if you're seeing micrometastatic disease or salt and pepper cancer cells, we may not see those on PET as well. So that's why there's still a 10 to 15% false positive or false negative rate in our PET scan patients.
Yeah. So 4D CT is must, in US or like high income countries, right? I don't know about the early stage or to the SBRT, is that required always to have 4D CT?
So, a 4D CT is ideal because you can see that patient with that lower lesion, the motion was not just superior inferior, but there was also some diagonal motion. And if you don't have a 4D CT, I do think there's experiences of doing inspiration breath hold scan, expiration breath hold scan, and then a free breathing scan, and then kind of drawing the volume between those. So sometimes that might be a larger volume than you would expect to treat. The other option, which I would typically do with a 4D CT, is to just do an expiratory breath hold, which may also be might not have the technology in that center, but inspiratory or expiratory scan, as well as a free breathing scan. So hopefully you can get the superior most image and the inferior most image as well as the central image.
Okay,
what are your thoughts, Dr. Sun, on that from a physics standpoint?
I think probably, I'm trained with 4D CT. I believe I highly recommend. I think, if you want to SBRT for lung, I highly recommend use 4D CT. It's definitely safer, right? You can see the motion. You can, make sure you include all the targets.
Yeah, I agree. Yeah.
Okay.
So let's move on to spine. I know there's limited time. So this is a 58-year-old patient with new onset lower back pain, radiating down his left leg, no other neurological symptoms. The pain increased with movement. And he was kind of sitting on his side to relieve the pain. A CT, he had a staging CT scan initially of just that area, which showed this L5 lesion, and then he had a full body scan, which showed a right kidney mass as well as a L5 spine lesion. He had no other disease in the body. And then he had an MRI for further evaluation, which showed this L5 enhancing mass invading the spinal canal and the nerve root on the left. And so this patient looks like he has a newly diagnosed kidney mass as well as this L5 spinal lesion. And so he was discussed by the urologist and said, while we talk about treatment for his kidney, as well as the medical oncologist, can you address this area that's having pain? You can see here that the disease is going into the canal, and as we'll see on the other next imaging, it's abutting the cauda equina, as well as the nerve root, which is right here as well. And so let's see if I can. There you go. Okay. And so with patients with bony metastasis in the spine, we really want to do a systematic review of neurologically, oncologically, mechanical, and systemic evaluation to see what's the best treatment for this patient. So we also use a multidisciplinary approach with neurosurgery, as well as our stabilization doctors to say, is there any neurological compromise? If there is, then maybe we need to do some surgery to relieve that neurological symptom quicker versus doing radiation. Typically with radio-resistant tumors, we doing stereotactic body radiation is beneficial. Those are patients with renal cell carcinoma, which are typically radio-resistant, or melanoma. However, with new data, it does show that SBRT can be used for oligometastatic disease and can be also improving patients with limited metastatic disease. And so more centers are using SBRT to treat spinal metastasis. You really want to check if they're mechanically stable or not, because if you worry about after stereotactic, if they can have a fracture or a compression fracture, which can also be debilitating. So if they're unstable, we really want to stabilize them. And then if there's disease going into the cord or spinal cord compression, if we can remove some of that tumor that's adjacent to the cord, then we can get better radiation dose coverage. And so this is a nice model that we use for our patients to making sure, are they an appropriate candidate for SBRT? And when we look at spine instability, there's a score called the SIN score, which basically looks at the location, whether they have mechanical pain, what kind of lesion it is there a collapse, or is there posterior lateral involvement? And basically, if they're 1 to 6, then they're stable and they're a good candidate. If they're 7 to 12, then you want to have neurosurgery intervention potentially. Or if they're a higher score, then it looks like they're unstable and they may need some stabilization. And so once the patient's evaluated, we try to see what's best for the patient. This patient was seen by neurosurgery. They did not think they needed to remove the disease near that was entering the canal, since there was no cord compression. And so his SIN score was between the 7 to 12 range. However, he did have neurosurgery input, and decided that we should go with stereotactic body radiation therapy for this patient. And so this patient was immobilized similar to the previous patient in a vacuolock bag. He can have his arms on his chest, which sometimes is more comfortable than having your arms on above your head. The main thing is we want them to be very comfortable. We don't want to have pitch, thin cut CTs, again, without contrast. And then we do a fusion with the MRI. We fuse both the T1 post as well as the T2 sequences. The T2 is helpful for seeing the spinal cord or cauda equina in this case. And the T1 is helpful for doing target delineation. So you can see in this patient, the tumor is contoured here. The GTV is contoured here in red on all 3 planes. This was with MRI fusion completed. And then if we look at the International Spine guidelines for target volume definition, depending on where the initial lesion is, they want you to create a CTV to encompass a part of the other part of the spine to make sure that there is no microscopic disease or have local failure adjacent. And you can see in every single one of these cases, there's part of the spine that is not part of the CTV. And I think that's intentional, so that way we can help our dosimetry and physics colleagues to have great plans that can have good coverage, but also minimize dose to the spinal cord. If we have the target all the way around, sometimes it can be challenging to create that donut in the center. So our patient is case number 2 example. You can see that the tumor was here, and so the CTV was drawn similarly. Here's the tumor, CTV. This is the spinal canal drawn. The equina was also drawn. And you can see that when we created the CTV, it abutted that. And then we did a 3 millimeter PTV minus the cord and equina, because we know that there's a PTV and then there's a PTV valve, which minus that cord and equina. So you can see it 3 millimeters adjacent, and then inferiorly, there was no margin there. And so there are a variety of fractionation regimens, from a single fraction to 2 fractions to 3 fractions, as well as 5 fractions. This patient was treated 30 gray and 5 fraction using the variety of planning objectives. These are some depending on the fractionation scheme you pick, 3 or 5. There are also other tables for 1 and 2 fraction. And so our important thing is spinal cord or cauda equina in this case. And so many times the PTV will not have 100% coverage similar to the lung cases because we have to spare the critical structure of the spinal cord. So in this case, you know, the goal is to have greater than 80% coverage and greater than 90% coverage of the CTV. However, you know, sometimes you may not have as good coverage, and it's important to spare that critical structure. And so spines separation surgery can sometimes help us. This was the plan where 30 gray was given to the target volume and margin, and then we gave 20 gray to the remaining CTV bone, so SIB approach. You can see that the spinal the cauda equina, which is drawn, is limited, and the cauda equina PRV is also limited to 30 gray here. We still approximately about 20% hot, and the conformality index for the PTV 30, which is the tumor alone with margin, was good. However, if we looked at the original PTV, which was touching the cauda equina, that was a lower conformality. So in patients getting upfront SBRT, it's pretty straightforward because they've never had radiation before. However, many patients, as the biology and evolution of their cancer, they may have been treated with, you know, 3D radiation previously. Typically, our standard, you know, palliative doses, you know, 30 and 10 or 20 and 5 or 8 gray times 1 sometimes. And so these patients may have progression of disease in a previously irradiated field. So this is a nice table from this paper about re-irradiation patients and worrying about the spinal cord tolerance. So this paper tells us that if the patients had 30 gray and 10 fractions, then you limit the thecal sac to 18 gray versus the 30 gray that we talked about previously in that previous patient. So this is a nice nice paper to reference as well. So these patients are also treated on the linear accelerator. We use our 6D couch to adjust for any setup uncertainty after doing a cone beam CT. And delivery is also, both of these patients were 2-arc treatments, so less than 5 minutes, and we use surface guidance to make sure the patient has not moved during the treatment. Any questions?
Any question, yeah, from audience about spine? I think probably Dr. Xu will cover mobile physics and
Sure.
set up immobilization. And I want to make a comments on, you know, set up your program, SBRT or SRS. Both physicists play a very important role. Make sure your patient is being treated safely and with high quality. So in the beginning, probably, you know, just work together, you know, from your immobilization, simulation, the treatment delivery, and also in the US recommendation by ASTRO and APM, medical physicists and physician has to be on site to verify the imaging registration between, for example, CT and CBCT on the machine. That's what we highly recommend. Okay, I would like to invite Dr. Xu to present, give a lecture about physics. You know, you can see that it's probably, you know, in terms of physics lecture will be probably very similar, and also we keep talking about a few key aspects about SBRT, invitation SBRT, and SRS. Yeah, so if you have any question, please raise your hand or type in the chat. Dr. Xu, you can share your screen.
Okay, thank you. So let me share my screen. Yep. Okay. Could you say it?
Yes.
Okay, pretty good. Okay. So I'll present the SBRT, especially for lung and spine cases, as a view of a physicist. So here is the outline of today's presentation. So I will briefly introduce the SBRT and then the process of the simulation and treatment planning, and also in the radiation delivery, including the patient position, immobilization, and target location. So for the lung SBRT, the breathing is a big concern. So I will also introduce the respiratory motion management, and then there are some specific QA items for SBRT cases, and also I will present some specific requirements for spine SBRT cases. Okay, so the major feature that separates SBRT from conventional radiation treatment is the delivery of large doses in a few fractions, which results in a high biological effective dose. So in order to minimize the normal tissue toxicity, the confirmation of high doses to the target and the rapid fall of doses away from the target is critical. So the practice of SBRT therefore requires a high level of confidence in the accuracy of the entire treatment delivery process. And the majority of patients treated with SBRT are those with lung, liver, and spinal tumors. So most investigators limit eligibility to well-circumscribed tumors with a maximum cross-sectional diameter of up to 5 cm. But there are also some centers you treat tumors as large as 7 cm. So the SBRT requires a precise the contour of patient anatomy, targets for planning, and a clear visualization for localization during treatment delivery. So in general, CT is the primary imaging modality for SBRT and forms the basis for many treatment planning calculations. The simulation study should cover the target and all organs at risk to obtain geometric and dosimetric information for the treatment setup. So a typical scan length should be extended at least 5 to 10 superior and inferior beyond the treatment field borders. So for non-coplanar treatment techniques, the scan length may further be extended by 15 centimeter inferior superior beyond the target borders to adequately model the patient. And for SBRT applications, the tomographic slice thickness generally in the range of 1 to 3 millimeter. So that is our recommended for most clinical cases. And the MR images is the golden standard for visualization of brain tumors, but it's also increasingly used in SBRT applications for prostate, spine, and chest or solid abdominal tumors. So PET-CT, that is very useful for identification of site of active disease and clear tumor contour. Okay, so for the treatment planning, so unlike conventional radiation therapy, so which is based on delivery of a uniform prescription dose to the target volume, a paradigm of prescribing dose for SBRT is based on the following set of conditions. So firstly, a limited volume of tissue containing the gross tumor and its close vicinity is targeted for treatment through exposure to a very high dose per fraction, and hotspots within the target are often deemed to be acceptable. And then the volume of the normal tissue receiving high doses outside the target should be minimized to limit the risk of treatment toxicity. So the gradient describing the dose fall-off outside the target should be very sharp. The SBRT, so just as a conventional radiation therapy, so also makes use of the ICRU50 and 62 to define the GTV, CTV, PTV, and OAR. So for the GTV, it has gross tumor volume, and it can be visualized in imaging scan. And the CTV, it has the clinical target volume. It accounts for the microscopic spread. And in SBRT, especially for the lung, liver, and spinal tumors, the GTV and CTV are often considered to be identical. And for the SBRT, so we have the spatial treatment range defined. It is ITV, the internal target volume. So it accounts for expected motion due to the respiratory and the organ failure. So the variation of in the CTV size and the position due to position added to the CTV to then generate the ITV. And then the PTV addresses all the possible geometrical variations by adding a variable margin for setup uncertainties, machine tolerance, and the intra-treatment variations to CTV. So the magnitude of the margins, it really depends on whether motion compensation is employed during the delivery. So the typical SBRT margins for defining the minimal distance separating the CTV and the PTV surface are 5 millimeter in axial planes and 1 centimeter in the inferior superior directions. And the dose prescribed in SBRT are often specified at low ISO doses, like 80% ISO dose, and with small or no margins for beam penumbra as the target edge. So comparing to the traditional radiation therapy. The rationale is to improve dose fall-off outside the target volume and have spare nearby organs at risk. So the practice increases dose heterogeneity within the target. So, but in contrast to conventional fractionated radiotherapy, so the dose heterogeneities within the target for SBRT are acceptable for targets, but not involving functional normal tissue. The hotspots within the target volumes are generally viewed to be clinically desirable. And the use of multiple non-overlapping beams is a primary means of achieving a sharp dose fall-off in SBRT plans. So in general, so for SBRT treatment planning, a greater number of beams yields better target dose conformity and dose fall-off away from the target. And when the number of beams is sufficiently high, the choice of beam direction becomes less significant. However, for practice reasons, it may be preferable to limit the number of beams or arcs, and we also tried to short the path of the beams. And for the long SBRT cases, so we always try to use partial arcs. So the restricting the entrance dose of individual beams to be less than 30% of the cumulative dose and avoiding beam overlap are desirable. So this will help to prevent acute skin reactions and maintain the isotropic dose fall-off gradients. So other parameters that affect the dose fall off are beam energy and the resolution of the beam shaping. For small beams, such as those commonly used in SBRT, the higher beam energy, the larger the beam penumbra due to the lateral electron transport in medium. So in a low density medium like lung, so this effect becomes more significant. So when we do the lung SBRT plan, so the 6 MV photon beam, so which is available on the most treatment machines. It provides a reasonable compromise between the beam penetration and the penumbra characteristics for SBRT lung applications. And additionally, so the most SBRT applications use MLC collimation. So while the final MLC collimation resolution improves the conformity of target dose distribution. So, but the commonly available 5 mm MLC leaf width has been proved, so it's adequate for most SBRT cases. So once the MLC leaf was reduced to 3 mm, so the conformity of target dose can be improved. But once the leaf was less than 3 mm, so that improvement effect can be negligible, except for the small lesions, generally less than 3 centimeters in diameter. And for the calculation grade, so the calculation grade resolution used in our treatment planning system affects the accuracy of the dose distribution. So the SBRT commonly included extreme high dose gradients near the boundary of the target and often makes use of the VMAT technologies. So it is recommended the use of non-isotropic grid size of 2 millimeters or finer. And so the use of grid size greater than 3 millimeters is discouraged for SBRT cases. And to evaluate the treatment plan quality, so the dose distribution of SBRT plan can be evaluated by the parameters, the plan conformity, and the dose fall off outside the target. So the plan conformity, so we can use the conformity index, which is defined as the ratio of prescription isodose volume to PTV volume to evaluate. And for a good SBRT plan, so the conformity index generally less or equal to 1.5. And for the dose fall off, so we can use the gradient index, which is defined as the ratio of volume of 50% of prescription isodose to the volume of the prescription isodose volume. And for the general SBRT plan, the gradient index will be less than 5. And for some centers, they are also use the R50 to evaluate the dose fall off. So the R50 is defined by the ratio of the 50% prescription isodose volume to the PTV volume. But for the R50, so it is really hard. It is really hard for the small SBRT lesions because the PTV volume is pretty small. So as this condition, so we also can measure the distance from the 50% isodose line to 100% prescription dose isodose line to evaluate the dose fall off. And there were some special dosimetry considerations for SBRT cases. So since the SBRT routinely use small fields and beamlets less than 10 millimeter in diameter, so to achieve our desired highly focused and precisely modulated dose distribution. So the measurement of a small photon beam is complicated by the loss of lateral electronic equilibrium and volume averaging, detector interface artifacts, collimator effects, and the detector positioning or position orientation effects. And due to the small dimensions and steep dose gradients of photon beams used in SBRT, so an appropriate dosimeter was a spatial resolution of approximately 1 millimeter, or better stereoscopic detectors is required to measure the basic dosimetry data, so such as the total scatter factor, or relative output factor, the tissue maximum ratio, and off-axis ratio. So that is really important for the SBRT commissioning. And the maximum inner diameter of a detector, so for the beam profile, so it should be less than half of the full-width half maximum of the smallest beam measured. So to deconvolution, to consider the deconvolution of the detector size effect. So the effects of the transient electron disequilibrium and increased lateral electron range in air. So it will result in an important reduction in the central axis dose beyond the cavity and potentially an underdose of the tumor. So the heterogeneity correction become extremely important in situations. So where the target is surrounded by low density tissue, like the lung SBRT cases. So the most treatment planning system used for SBRT make sure you make use of one of a variety of advanced photon dose calculation method. So it's based on Monte Carlo pre-calculated dose spread kernels and employing convolution or superposition techniques. So for the pencil beam algorithm, is accounting for only 1D scatter correction that are not recommended for accurate estimate of the dose in a target surrounding by low density tissue. So for example, the dose calculation using pencil beam superposition will not account for increased electron scattering in low density material. And the pencil beam algorithm, it cannot account for the lateral scattering in small field size using SBRT. So the degree of required immobilization for SBRT is largely influenced by the ability of the dose delivery system to both detect and correct for the changes in patient position that may occur during treatment. So even current image-guided positioning system reduce the positioning error, but it cannot eliminate the need for the proper immobilization. So the table here summarizes historical immobilization strategies and their associated localization errors. The body frame serve both to immobilize the patient physically and provide an initial approximation target localization, so which is subsequently refined by in-room imaging guided techniques. The body frame technically make use of vacuum cushions for immobilization, and the localization and the targeting can be facilitated by a localizer arch, which can be affixed to the body frame or to the Linux couch top, and defines the reference coordinate system of the body frame fiducials. So some body frame systems also include the equipment for abdominal compression, which can be used to minimize the respiratory motion. The imaging guidance provides the finest level of localization and is used to reduce the spatial uncertainty in the positioning of targets and possible critical structures prior to radiation delivery. So in its more advanced implements, so image guidance is also used to monitor the position of target or surrogate during the radiation delivery. The traditional approach has been used of 2D MV portal imaging. So this approach used in conjunction with implanted fiducial hardware. So it has been used to deliver SBRT treatment to spinal sites. So which can keeping the target within 2 millimeters of its planned position. The volumetric imaging guidance allows for the precise localization of bone and soft tissue targets. So it can be achieved by MV or KV cone beam scanning. So the dual or multiple room mounted KV imaging system are also used to provide rapid 3D localization of target or implanted markers using pairs of 2D radiographs for both patient setup and intrafractional monitoring. The treatment machine was gantry-mounted KV units capable of fluoroscopy, radiographic localization, and cone beam imaging. So it's especially for soft tissue targets are being widely adopted. So this had a profound effect on SBRT. The onboarding imaging. So the OBI system, which is used in various Linux machine. So when integrated with the imaging registration software, it can make accurate target position and verification for SBRT. So like the picture shows, so we registered the CBCT was the planning the CT, and then the registration software can automatically calculate so how much shift or the rotation of the couch can make position or localize the patient to the planning position. Okay. So after the localization, so there is some kind of monitoring is desirable to track patient breathing and monitor patient positioning during treatment. So two optical technologies, so the stereoscopic infrared cameras and video photogrammetry are used to track the 3D coordinates of points on patient skin in real time. So the infrared tracking system using either active infrared lighting, the light emitting dials, or passive markers on the reflect the light emitted from an external source. So these are temporal, all these markers and the reflectors. So the light emitters, they are temporarily attached to the patient's skin. So in this system, the infrared cameras are used to track the light emitting dials or reflections in 3D during the treatment. The video photogrammetry system uses several video cameras and speckle textured light projector to acquire a 3D surface without the need to attach any markers to the patient's skin. And some systems combine the in-room optical systems with KV imaging to detect the changes in correspondence between the external markers and the tumor over the course of the treatment. So the reported positioning accuracy of the tumor tracking system is around 2 millimeters. So this part, the management of the respiratory motion, so that is pretty important for the lung SBRT cases. So if the respiratory motion is not accounted for, so it causes artifacts during the image acquisition. And these artifacts cause distortion of target volume and incorrect the positional and the volumetric information. So the figure showed here is a frontal view of CT scans of the same patient taken during free breathing with artifacts that part A, and was the respiratory gating scanning as exhale phase. So that is a part B. So during the treatment planning, margins need to be large enough to ensure coverage of the target for most of the treatment delivery. According to the breathing motion, by adding treatment margins to cover the limits of motion of the tumor, that is suboptimal in SBRT cases, because this strategy increases the radiation field size and consequently the volume of healthy tissue exposed to high doses. However, if the margins are not sufficiently large, part of CTV will not receive adequate dose coverage. And because of the artifacts observed in CT images, so in which the breathing has not been accounted for, the magnitude of margin to allow for motion is difficult to quantify. And the interplay, so during the radiation delivery, the dosimetric artifacts due to the interplay between the MLC sequence and the target motions, so will cause the inhomogeneous dose distribution, which may be cause the target underdose or overdose within the target. So the 4D CT is essential. It is essentially a CT video that displays the motion throughout the breathing cycle. So it acquires repeat images over more than one breathing cycle at each stationary couch position. So image acquisition is time synchronized with the breathing signal, and then images are sorted with respect to breathing signal, a set of volume images at a different particular breathing stage. So the 4D data can be analyzed to determine the mean tumor position, tumor range of motion for treatment planning, and the relation of the tumor trajectory to other organs. The MAP imaging, so it is created by combining the voxel with the highest attenuation volume across all phases of the 4D CT. And a dense moving lung target appears as a large bright object in the MAP. So this is the illustration of the average CT and the MIP CT. So and this is the example of a 4D CT. So when a 4D CT is not available, so we can take CTs at inhalation and exhalation and uses them in conjunction to estimate the extent of tumor motion. So this technique provides less accuracy than true 4D CT, but does not require a specialized CT scanner. And there is other option to replace the 4D CT. So that is a slow CT scan. The projection data is collected over a time much longer than patient's breathing cycle, and then the resulting image so is similar to the maximum intensity projection with significant motion blurring and increased patient dose. And there is other method called the respiratory gating. It involves the administration of radiation during both imaging and treatment delivery with a particular portion of patient's breathing cycle, commonly referred to as the gate. So the position and the width of the gate within a breathing cycle are determined by monitoring the patient respiratory motion using either external or external respiration signal or internal fiducial markers, like what we get the breathing signals in the 4D CT. So since the beam is not continuous delivery when we use the gating method, so it produces longer treatment time than the non-gated procedures. So when we treated the lung SBRT cases with the gating method, so we always prefer the high dose rate to short the treatment time. So for the SBRT, the imaging and treatment, they are synchronized with patient's breathing cycle, and then increasing the potential for CTV to PTV margins reduction. As the dose is delivered only in particular breathing phases, so with the goal of reducing the probability of deliver the dose to normal tissue and underdosing the target. Okay, so here are some specific QA process requirement for SBRT cases. So it is the difference between SBRT and non-SBRT machine QA focuses on the imaging system and the couch motion system. So for here in the daily QA, so the non-SBRT imaging accuracy as the tolerance is 2 millimeter, but for SBRT that is 1 millimeter. And for the treatment couch position, so the accuracy of the general MRT cases is around 2 millimeter 1 degree, but for the SRS is 1 millimeter and 0.5 degree. So the SBRT cases has the more tight or more narrow tolerance. And this is the table, so which summarizes the published overall accuracy of various SBRT treatment processes. So the Wilson loss test, so it is used to verify coincidence with mechanical isocenter, including the couch rotation and laser alignment to the radiation isocenter. So it mounted a BB at the top of couch and aligned the BB with laser or imaging to isocenter, and then took multiple portal images of small static fields at different gantry, collimator, and couch geometry. So in portal images, the center of BB presents mechanical isocenter, and the center of radiation field represents radiation isocenter. So for SBRT, the offset between BBs and the radiation field center should be within 2 millimeter, and that tolerance will be reduced to 1 millimeter for SRS cases. And in our center, we do the Winston loss test before the SBRT treatment daily. And for the patient-specific QA, so we can use the portal imaging to evaluate the the calculation, the TPS calculation, and the deliverable of the plan. So for the portal imaging, so we get the imaging fluence from the radiation, the treatment field, and then we can convert that the photon fluence to doses, and then to generate the gamma index of the plan comparison. And there are also measurement-based patient-specific QA. It can be achieved by the map check. So, but for the SBRT, so we cannot use the general map check, which is the space between the diode around 1 cm. So we have to use the map check for SRS or SBRT plan. So like this PTW SRS map check. Sorry, that's not PTW. The SNC SRS map check showed here. So the space between the space between dials in the map check is less than 1 millimeter. So it's a pretty precision in the dose distribution measurement. And for the spine SBRT, so there are there are a little bit difference with the general or the long SBRT cases, because in most SBRT cases, the isotropic dose gradient is desirable, but the SBRT for the spinal tumors so usually requires the irradiation of the vertebral bone or non-attached soft tissue tumor growth. So and then we have the spatial consideration to spinal cord, which is a few millimeters away. So and then isotropically sharp dose fall around the tumor, it may result in an unacceptable dose to spinal cord for such a case. And there is a report. So there, if we use 9 to 11 posterior and posterior oblique beams equally spaced 18 to 20 degree apart, have been shown the sharp dose gradient up to 12% per millimeter between the target and the cord, and with a more than 90% dose coverage for the target volume. And there is other condition for the spine SBRT. So there is maybe the metal implants, so just beside or in the treatment field. So when we take the KV image, or the like the KV CBCT, so the artifacts will really serious to prevent you localize the tumor accurately. So at that time, we can use the change to use MV portal images to reduce the artifact and to align the patient. This is a reference for this session, and okay, that's all. Thank you.
Thank you very much. I saw the reference. You know, in the US, we pretty much follow AAPM guideline, but I know many, you know, worldwide, many of them follow IAEA guideline. They are very similar, to be honest. Yeah. Any question? By the way, thank you so much, Dr. Xu, and this is a great presentation. I saw a question for the liver case. Let's see, confirm it's good. No. Okay. For the liver case, would you recommend using a compression belt or exhale breath hold? That's a great question. Actually, our next session will address that. So our next session, we're going to focus on the liver and the pancreas. So please join us. And by the way, we start at 8 a.m. US Central Time. And I know every time about 9 o'clock, I saw more people are joining. Definitely it's the time zone error. So please pay attention to time zone and also the email from Geneva. Any question? By the way, this video is also recorded. Let's see, I have questions here. You should need dependent for patients with QA, which I consider it always the best option for this kind of QA, but what do you think about TG307? Okay, that's a very good question, actually. I'm also the task group for TG330 using the EPIT photodosimetry for machine QA, but this is for patient QA. Yes, I agree that you can use photodosimetry for the patient QA for SBRT. However, in the beginning, when you implement your SBRT or SRS program, I highly recommend you use a secondary method, ion chamber, to verify patient dose. The reason is that photodosimetry is kind of measured fluence, and the output factor, for small field is critical. So ion chamber can tell you the information. That's the reason why. Once you feel more comfortable after you treating, for example, 100 cases, I think you can use photodosimetry PS, follow TG307. It's okay. Yeah. Any more questions? I saw someone also post a review. Yes, I think it must be a very good one. Feel free to read that one. I will also read it. Yes, there's many recommendations and review papers. Again, this training, the time is very limited, right? So we cannot cover everything. That's the reason why the reading, and also if you have any question, please let us know. And also please provide your feedback to see how we can continue to improve this training session. And also especially, but these lectures only give you fundamental idea, the basic principles. And every institution is different, right? You have different equipment and you have different needs. But here we focus on the basic principle, universal ideas, how you can implement SBRT, SRS, for different disease sites. Okay, thank you very much. I really appreciate it. And have a good night, good morning, and good afternoon. I'll see you next time.
Thank you.
Thank you.
Okay, let me stop the recording.
Thank you very much.
Thanks.